like I said, we had it 3 times a week. And then as it slowed down, the COVID, then it became twice a week, and then it went to weekly. But then the Infection Control Committee as such still met on the monthly basis, because we had to then, I spoke about how you had to introduce new policies. So at that time, we could then reiterate any new policies that had come out in between all the other meetings and regulations and guidelines that were coming out from NICD and Department of Health. So I hope that answers your question. It's a rolling ball, and as things develop, so then you up your meetings and you keep them short and sweet and to the point, so that people can actually get back into the units and to actually carry out and implement what has been suggested. Thank you.
Thank you, Michelle. My next question is directed towards Evelyn, and Sinai is asking here, like, what strategies did you employ for leadership buy-in and support? Over to you, Evelyn.
Thank you so much, No. And Sinai, thank you for the questions. I just want to maybe point out at one strategy that actually got the leadership to buy in and support the IPC programs, and that's data that has generated. Once you carry out an audit and you're able to present these findings to the leadership, and they begin to see their facility in light of the kind of feedback that the audits or the assessments provide, it's one of the avenues that actually gives them a lot of support for the program. The other bit is when you have data and you can put a cost to it, it actually also supports and encourages leadership buy-in. And I'll give a simple example. When we had a lot of our instruments, let's say, being soaked in chlorine bleach, and we had a lot of rusting instruments, so management kept buying these instruments, and it was very hard for them to change from the chlorine bleach to an enzymatic detergent. What this one specific facility did was just cost. What does it cost the hospital to buy an enzymatic detergent versus buying new instruments every other month? So when leadership begins to actually see that IPC interventions can save on costs and also save lives, it makes a big difference. When they realize that the hand hygiene compliance, for example, is 0, that is usually a wake-up call for the facility. And when they realize it's 0 because their facilities don't have soap or they don't have alcohol-based hand rub, which is not very expensive, then they are able to act on their own data. So I think that is one of the biggest strategies that you can use. It is very effective, locally generated data, and then after that, you can build their capacity. When you train them, they realize that infection control is not just what they thought about having a clean environment or well-trimmed grass and flowers, that it goes beyond what. When they get this realization, we normally see that we have better buy-in and we have support even to the budgetary allocation level. Thank you.
Thank you, Evelyn, for that detailed answer. My next question is to Prof. Robertson from Zimbabwe. There's Ms. Manjezi who is asking, how do you incorporate IPC into the new nursing curriculum? Over to you, Prof. Robertson.
Thank you, Lizzie. What we did here in Zimbabwe, we talked to the curriculum committee responsible for the nursing curriculum in the country. And our system works very well. The curriculum, we have several schools of nursing in different health facilities across the country, and they all teach the same nursing curriculum. So we started by presenting to the committee what should be in a basic IPC course. So this was a 5-day course, probably similar to the one that's is taught in Kenya, dealing with the basics of an infection control program. And so they reviewed their different nursing curricula, because there were the registered, the RGNs, there were some specialist diploma course trainers there as well, and then looked at how they could incorporate basic IPC into the teaching program. So this is what happened. And then when COVID-19 came along, the curriculum was again reviewed to see how the IPC aspects, as well as things like case management, could be upgraded in the teaching curriculum. So that way we have an ongoing continuing review that helps make sure that particularly the nurses, but we did this for medical students, we also did it for physiotherapists, so other health professionals as well. So I think you have to start by looking at the curriculum, see what's needed in terms of basic IPC, and then see in which first year, second year, obviously they need some basics in the first year, then see how it can be incorporated. Other people may have done it in different ways, but that's just an example from Zimbabwe. Thank you.
Thank you, Prof. Robertson, for that. The next question is directed to Evelyn, and this is a question from Joanne Ejambi. Is asking, how were resources for IPC generated at facility level to fund the activities? Over to you, Evelyn.
Thank you, Joanne, for that good question. How are these resources actually generated at facility level to fund activities? Like I mentioned earlier, when you have data from an assessment activity that has been conducted, and maybe you realize that all that you require is taps to be fixed, or sinks to be fixed, or soap and alcohol-based hand rubs to be bought, or paper towels that need to be bought. These are things that would normally be within a hospital budget. So the facilities did not necessarily have to identify new sources of funding, but they actually worked within their own existing budgets. It was just a matter of reprioritizing and reallocation of funding. Even before they got their own budget lines, the committee realized that when they are making budgets for soap or alcohol-based hand rub, they just needed to increase, because now they are more aware of their needs and their consumption, or their quantity, or the quantities that they require to use. That was one way. The other way that the facilities also were able to generate resources at that level to fund the activities was by engaging partners. When you have a work plan, you can actually confidently engage a development partner, because then you can identify your priorities and you've put a cost to it. So they were able to know we cannot print job aid. So when a partner comes on board, they just say, we have the standard templates. Can you be able to reproduce this for us? So that is the way that the facilities are able to generate funds. And where the engagement had been optimal, some of these facilities actually have their own budget lines for infection prevention and control, because the committee also is tasked with the responsibility for budgeting for their IPC requirements. It does not happen at the beginning, but with continuous engagement and continuous generation of information and feedback, slowly they begin to get their own budget lines, because they are recognized as a critical component of service delivery within the healthcare facility. So it's at that 3 level, using the existing budgets within the facility, just reprioritizing and reallocation of funds. Number 2, raising funds through implementing partners that would otherwise support many other things, but then now the IPC committee is more aware of what is required. And finally, by getting their own budget lines, which I know takes time, but eventually with the advocacy and engagement of leadership, is something that is possible. And it has happened in hospitals and their own activities at the IPC level. Thank you.
Thank you, Evelyn, very detailed. My next question is to Prof. Shade. How do we, this is from Ajulo, how do we set up IPC in an undeveloped and ill-equipped primary healthcare center where there is only one doctor and 2 nurses without a pharmacist or a lab scientist managing the primary healthcare center. This is very difficult, and is there a possibility for an area or regional IPC that can effectively inspect these primary healthcare centers? Over to you, Prof. Shade.
Thank you very much. First of all, I'm going to I think there are like 2 or 3 questions in that question. So I'll start with the first one, which is how do you set up an IPC committee in a small facility? Let me say that the committee, or should I say the overarching IPC supervision, the size and complexity is determined by the size of the healthcare facility, the complexity of the things that you do. So at the primary healthcare level, you might just need one person, an IPC focal person, who reports to the facility manager. And so it doesn't have to be complex. And don't forget, when we're talking about IPC committees, and all we are saying is have a policy forming body that makes sure that the IPC program is cohesive, is coordinated, and achieves the goals that you have set. So in a primary healthcare facility, you determine what are the things that you do and ensure that you have all the policies, the procedures, and you ensure that they're carried out properly. So you may not need more than one person because it's a very small facility. So you don't need the complex, you don't need to have many people. You don't need the lab scientists, the pharmacists. You may not need all those people at all because, again, it is tailored to what you do. I hope that helps. Then the other part of it, sorry, let me just mention a little bit more. Now, if you have the one good thing that came out, and which we do know, is mentorship. It's always great if you have a bigger facility, if there's, that you maybe refer to that may have a bigger IPC program that you can shadow to learn how to do it, who can mentor you and whom you can report to. Sometimes this may be at, I don't know, different countries have different structures in place. It could be, when I use the word ministries of health, but it could also be at the local government level or the district. I mean, at various levels of the healthcare delivery system that oversees it. But what we find in many countries, again, is that those systems don't exist. So if you have a bigger hospital, then you can reach out to them and they can work with you to mentor the people on ground. That also has been something that people do. And of course, the Infection Control Africa Network will be happy to work with any facility that needs assistance. Thank you. I don't know if that answers your questions.
Thank you, Prof. Shade, for that. And I know we've just gone past our time, but No has allowed me to ask one last question. And I will pick the question from Maureen Kesande. She's asking from the Zimbabwe and the Kenya presenters, how have you been able to obtain routine IPC data from health facilities? How consistent has it been in your experience? So I will start with Evelyn and then thereafter Prof. Robertson. Thank you.
Thank you, No, and Maureen, that's a good question. And like I had pointed out in our challenges, one of the areas that we've not been able to fully address is having a clear monitoring and evaluation system for infection prevention and control. So what that means is that we've not been able to set a system that will enable us to obtain routine IPC data. As much as we have a national infection control assessment tool, it has not been embedded in our routine practice. That is one of the things that we are focusing on this year and the coming year, just to make sure we have a system that can collect data. So we were able to just generate data from a national perspective during this COVID response. We developed an app with the support of one of our partners. So we were able to actually get data on a one-off. That's not routine. So that means it's not part of our system in terms of monitoring and evaluation. So to answer your question, it has not been consistent in our experience. We've only attempted it once on a large scale, and the use of our infection control assessment tool to help us scale up our CQI interventions. So that's not a large scale, but when we have scaled up this intervention, that data has been collected on a monthly basis, and it's just been basic data on hand hygiene and waste management. And we just started collecting data on surgical site infections, post-cesarean section procedures. So that is not routine because it was still under piloting, but we hope to scale it up now that we have a better understanding of how data should be collected. Thank you. Over to you now.
Thank you, Adrian. And over to you, Prof.
Thanks very much. I think we're in a very similar position. We have some IPC indicators, such as do you have a functioning IPC committee at your facility that's collected by our quality assurance department, but it's not regular, and the data we do collect tends to be associated with different projects. We did an audit of, I think it was about 40 facilities using the WHO IPCAV tool to look at the implementation of the 8 core components described by WHO. And that did give us a view of what was going on in different levels of healthcare. But like Evelyn, it's not consistent. It's something we're working on. We're trying to identify indicators, IPC indicators, that are relatively easy to report, but also reflect the functionality of the IPC program, which is not an easy thing to do. So it's work in progress. Thank you.
Thank you, Prof, for that response. And I note some of the questions that have been that are being asked, some have been responded to. And for the remaining ones, I think we are going to compile the list and try by all means to respond to them and send through the community of practice or through the emails. At this time, I would like to thank the presenters and the panelists for this Q&A session, and to hand over to No. Thank you.
Thank you so much, Lizzie, for that interesting session. Unfortunately, time is not on our side, and we would have loved to answer all the questions, but we'll try and address as many as we can individually after the questions are compiled. I'd like to thank all the participants, all the panelists, all our presenters for attending this session, and for all those who are supporting the session behind the scenes. Just a reminder of our French session on Friday every week, and the reminder to register and join us next week for week 2 of Series 7. I mentioned earlier on during the introductions that the sessions are recorded, and that these will be made available to all our participants who are registered. The lectures will also be available on the ICANN and CDC websites. And then if you've got any questions that are burning, please send your questions to Susan Kessie. Kessie is KESSYS at africa-union.org, or to Anna with ICANN at Anna at icannetwork.co.za. And with that being said, thank you so much for taking part in this, and we hope to see you next week. Have a very lovely day. Bye.
Bye.
Bye. Thank you.
Okay, bye-bye. Thank you very much.